Thank you very much. Thank you very much for the invitation to talk here, to present here. I do realize we are changing gears, not for the day-to-day practice which has been addressed in these lectures before lunch. But I hope that in one way or the other it may affect also your daily practice. And the other challenge I have, it's immediately after lunch. So we'll see whether you can keep all the attention to hand function as an outcome measure in clinical trials. These are my disclosure, and actually I do have an additional disclosure, but I'll come to that later on in the presentation. What I want to talk about is the arm-hand function. Arm function, hand function is try to combine the upper limb. Why measuring it, how to measure it, what the experiences are in clinical trials in progressive MS with related to upper limb function. Explaining something that I've called, but that's probably, I'm not a native English speaker, you probably noticed already, but what I call the mobility dexterity shift, the difference between the ambulation and the upper limb function. And what could we do in future trials in progressive MS? So the first thing is why measuring arm and hand function? Well, it's probably not that problematic to think about the importance of it. I mean, I hope you all had a wonderful lunch, and if you realize yourself that you're wheelchair bound having lunch, then you probably would have had a nice lunch. If you don't have the ability to move around your arms and hands, you would have had a much more difficult time. So it is of clinical relevance for all of us, and of course also for people with MS. And the other thing is that it may be increasing your chances of a successful intervention in progressive MS trials, and I'll come to that later on. The clinical relevance of arm and hand function is, of course, for the activity of daily living, and that's both for the basic activity of daily living, like bathing, clothing, and things like that, but also for the instrumental activities of daily living, like cooking or using your mobile phone, although I have the impression that using the mobile phone becomes a basic activity of daily living in most people. It's important for independent living, of course, and it's also related to employment. It's not only that aspect of MS, there's also cognition, it's also fatigue and other things, but apart from that, also arm and hand function is related to employment or unemployment, and it has a huge impact of the quality of life. How can we measure arm and hand function? There are performance tests, there are patient-reported outcome measures, but of course you can also observe while doing daily activities, and that's something that we have been trying to do that in a standardized way with video capturing daily activities from upper limb function. The problem is that it is very difficult to have it scored in a very standardized way. So if you do that in a neurological examination, you have a good impression of the upper limb function, but it's very difficult to have a real, let's say, objective scoring system with a good intra and inter observer reliability. So we have performance tests and we have patient-reported outcome measure. With respect to the performance test, the 9-hole peg test is probably most widely used upper limb function. There are more tests, like the box and block test, like coin rotation, which is probably more limited to the fingers. But the 9-hole peg test is a test that has been used very much, very often. For those who are not aware or not familiar with it, you have a bucket with 9 packs. You start with all the packs in this bucket. You start the stopwatch, and one by one they should be put into these holes and taken back out again until the last drops into the bucket. And that's the number of seconds you are using is the score you have. So that's a kind of objective. There are all kinds of challenges. Even you can see that this is well, it's kind of a bowl. So if you are with when you have a problem in your coordination, you can dive into that bucket and you lose almost all packs. So what do you do then? So there's strict rules on how to do that. In the box and block test, it's more simple. So this is most widely used. It's part of what we call the MSFC, the MS Functional Composite Score. Downside of the composite score is that it's combining several items, and it's a single score. You cannot dissect the upper limb function. There is, and this is definitely my other conflict of interest, there is also now a patient-reported outcome measure for arm function. We've developed that. There are also arm function prompts that are developed for instance, stroke and other circumstances. They have been used. It's not ideally focusing on the problems you encounter, although some of these problems are, of course, generic. This is developed for using as a kind of item bank for computer adaptive testing eventually, and now we are in the process of trying to develop a computer adaptive testing system. We have a short form, but these are still 31 items, which is quite a lot. You can see that the information on this is where the problems arise in this part of the scale, and there you have a lot of information. You have a low standard error, so that is doing quite well on a unidimensional scale. And we have now this available in 6 languages, and all these items seems to have the same meaning in the different languages, so you can use it across the countries. Going to the clinical trials in progressive MS, these are the outcome measures mostly used with respect to EDSS, and you see that the majority are EDSS-related primary outcome measure, and then you have secondary outcome measures, all related to EDSS. It may be a change in EDSS, it may be a confirmed worsening for 2, 3, 4, 6 months or whatever. So it's all EDSS-driven, because EDSS is has been and is still the most widely used outcome measure in clinical trials in multiple sclerosis, including progressive MS. And you do have a lot of secondary and exploratory outcome measures not related to EDSS, like, for instance, what I just mentioned, the MSFC, the MS Functional Composite, that contains arm function or upper leg function with the 9-hole peg test, but also walking with the timed walk test, and a kind of cognition test called the PACE set. For those of you perhaps not familiar with EDSS, this is a scale going from 0 to 10, death due to MS, and in progressive MS it's mainly these patients that are included between 4 and 6.5, and in this part of the scale it's fully driven by ambulation and by the use of support. So in fact, when you are measuring in this part of the scale, you don't measure all aspects of neurological functioning, more or less exclusively walking. In the lower part of the scale, it's a neurological examination, and in the higher part of the scale, there it also comes to brainstem functioning, but also arm function and ADL. That is whether you have effective use of your arms or not, is expressed in the scores at the higher end of the scale. So because of the majority of the trials including these patients and using this as an outcome measure, they are more or less completely focusing on mobility. And just to start with the first trial, one of the last trials that showed a significant effect on these EDSS outcome, the 12-week confirmed disability progression, you see the separation of these two lines, ocrelizumab and placebo, and that reached statistical significance, which is, of course, a combination of the magnitude of the effect and the number of patients in the trial. When the patients' number are lower, then it's harder to reach statistical significance and vice versa. Going back to a very old trial in 1995, a very low dose of oral methotrexate in secondary progressive or in chronic progressive multiple sclerosis. It's nice to see that the EDSS didn't reach statistical significance, probably because of the lower number of patients in that trial. Ambulation didn't reach statistical significance, but we do see a difference in the 9-PEC test and the box and block tests, so that eventually the trial turned out to be positive because of upper limb function. So here there is a separation between the ambulation, the walking ability, and the upper limb function. There is a trial, the AVONEX trial, that used the MSFC as the primary outcome, and when you look at it, it did reach statistical significance. It has been debated a lot because it didn't reach statistical significance for the EDSS, which was at that time still, let's say, the dominating outcome. But it did reach, and it was chosen on beforehand, statistical significance on the MSFC, and that was by and large driven by the upper limb function. Didn't reach for the timed walk test, and it's not statistically significant for the pace set. So also here it is interesting to see that you have two trials in progressive MS that seems to work for arm function or upper limb function and doesn't seem to work for ambulation. In a single center study of interferon in progressive MS, it turned out that the EDSS as an outcome measure didn't reach significance. These lines seem to separate more or less the same, but the number of patients are much smaller. And looking at in the same trial at the MSFC, it seems to be that there is a difference between the MSFC in the placebo group and the treated interferon group. You're never sure why and how it's different, but it seems to be. There's no definite conclusion. Interestingly, in this trial, this 2-year trial, there was a follow-up after 5 years. At the end of the 5 years, you look at the end of the 5 years after the 2 years on trial. You look at the differences in these two groups. So these are patients treated with interferon, and then after 2 years, the treatment stopped because that was the end of the trial and the trial was negative. These are patients on placebo for 7 years. These are patients on placebo, not on active treatment for 5 years. And when you look at the 9-PEC test score, you see the arm function that there is a significant difference between those on interferon and those on placebo in the first 2 years of trial. So that's interesting, and I can recommend to reading this article, and show it in a minute, because this is a possible explanation that in these 2 years on trial, there's something happening in the central nervous system that changed the progression for the upper limb over time, and then at the end of these 5 years, you do find the difference between the two arms. So although it's only a 2-year active treatment trial, there is a substantial difference after 5 years. So maybe has something happened in the period of the treatment. And this is the article I'm referring to. It's not because of the chair, but I think it's a very readable article, and it's very provocative to think about how things can change the way we look at the pathology in multiple sclerosis. And I think there are a few explanations why there is a difference between lower limb function and upper limb function. And I quote from that article. This is one of the possible explanations. If getting new lesions, getting new inflammation is more a kind of a random process, it's likely that, or it's obvious, I should say, that when you have a longer axon, that the chances of being struck by a new inflammatory lesion is higher in those with a long axon than in the short axon, and that may be the difference between the lower limb and the upper limb. And if repeated activity in that system prevents really the healing and eventually leads to degeneration, then also the more longer axons are more vulnerable to this degeneration, which is, let's say, shown here for as long as it's still visible. So these longer axons tend to degenerate more frequently. And that could explain why the lower limb function is worse in an earlier phase of disease and harder to influence over time compared to the upper limb. And that would lead to differences in the window of opportunity to treating different systems. So there is not specifically a window of opportunity of treating MS as a whole, but comparing the different systems may lead to different windows of opportunity. And if this is the time where we can diagnose the progressive phase of the disease, or we are convinced that the patient is in the progressive phase of the disease, this window of opportunity for the lower, the motor function of the lower limbs may be gone and still present in upper limb motor function. And that could also explain why in these older trials and in the trials for the using the MSFC, that arm function was influenced by the treatment and leg function, so mobility wasn't. So, concluding remarks, I think I catch up some time. I think arm and hand function is clinically relevant. I think it's not only relevant with respect to trials in progressive MS, but it's also very relevant in day-to-day practice, and we could or should take more attention to it. Treatment initiated in the progressive phase may be in the window of opportunity with respect to arm and hand function, so it may be a very sensitive and sensible also outcome measure for RCTs in the progressive trials. I think we should consider including that. And we have the availability of both performance measures as PROs, and patient-centered outcomes are increasingly required by regulatory agents, so that also offers an opportunity. And well, life doesn't stop at EDSS 7, I would say. Thank you very much.